Pitfalls in managing infants and young children on mechanical ventilation. 1. Inappropriate application of adult ventilation strategies. Ventilation protocols based on adult studies may not account for the unique anatomical and physiological differences in infants and children, such as higher airway resistance and lower elastic recoil of the chest wall. This can lead to suboptimal ventilation settings and increased risk of lung injury. Two. Underestimating the risk of air trapping and hyperinflation. Infants' relatively small airway diameters and disproportionate lung growth predispose them to air trapping and hyperinflation, particularly in conditions like bronchiolitis. Failure to recognize these risks can exacerbate ventilation difficulties. Three. Overlooking the impact of high chest wall compliance. Infants have highly compliant chest walls, which absorb part of the ventilatory effort, increasing the work of breathing. If this is not accounted for, mechanical ventilation may fail to adequately support the patient, leading to respiratory muscle fatigue or lung collapse. 4. Failure to prevent ventilation-induced airway damage. Prolonged or improperly set mechanical ventilation can cause deformation of the airways, such as tracheal dilation, cartilage disruption, and thinning of airway muscle. Five. Ignoring the lack of collateral ventilation pathways. Infants lack well-developed collateral ventilation, making them more prone to atelectasis during airway obstruction or insufficient alveolar recruitment.
Infants' diaphragms are less efficient due to reduced muscle mass, lower oxidative capacity, and suboptimal insertion points. Misjudging their capacity for spontaneous breathing can lead to premature extubation failure or prolonged ventilation dependence.
The disproportional growth of airway size compared to lung tissue volume in infants increases susceptibility to gas trapping during exhalation, particularly in conditions of increased RA. Ventilator settings that do not address prolonged expiratory times can exacerbate this problem.
The interplay of high airway resistance, low chest wall elastic recoil, reduced diaphragm efficiency, and lack of collateral ventilation creates unique challenges. Overlooking the cumulative effects of these factors can lead to critical management errors and poor outcomes. Addressing these pitfalls requires tailoring mechanical ventilation to the unique physiology of infants and children, emphasizing gentle ventilation strategies, close monitoring, and proactive adjustments to minimize ventilation-associated complications.